Hello, my dear students. I'm Dr. Vaishaly Bharambe. I've been teaching anatomy for more than 25 years and I love it. This lecture is an important lecture out of my CNS series, Central Nervous System lecture series on the spinal cord. These are all the spinal cord related lectures that have been created by VB Anatomy. I request all of you to attend this. Not because it will benefit me. Of course, if I get viewership, it will benefit me. But it will benefit you. See, you have a strong foundation of understanding of spinal cord. It will take you far in your study of CNS. You cannot know brain without knowing spinal cord, believe me. Okay? So my strong advice to all of you is study your spinal cord well. Use all these lectures, they are made for you. One small request from me. Every time you like a lecture, please just share it with one friend of yours. That's all. Just share it with one. Let somebody else also benefit from something you have liked. Okay? Right. So this lecture is about lesions of spinal cord part 1 and part 2. Part 1 has already been covered and released. This is part 2 of the series of lesions of spinal cord. So let's begin. Anatomy of lesions of spinal cord part 2. Students, in my last lecture I told you that the best way to approach a spinal cord lesion is as follows. 1. Understand a section of spinal cord. Which tracts are going up? Which tracts are going down? What is the grey matter? So understand that. Okay. Next is understand what are the signs and symptoms of lesion of each tract. Extrapyramidal gaya to kya hota hai? Pyramidal gaya to kya hota hai? If I lose my lateral spinothalamic tract, what is the symptom I will see? Learn up all this. Understand it. Okay? It should become kind of default information. And of course, just introduce yourself to the concept of lamination. I'll touch on it today again. So just for all of you, the link for that last lecture is given in the description section. In brief, I'm going to just run through it. These are all the descending tracts. As you can see, this is a section of spinal cord. The tracts labeled in red are the pyramidal tracts. Lateral corticospinal, anterior corticospinal are pyramidal tracts. All others are extrapyramidal tracts. These are the descending tracts seen in spinal cord. Here on this side, I have labeled all the ascending tracts for you. Of course, both tracts are found on both sides. This division is only for ease of understanding. So all these on this side are the ascending tracts. Please go through this. What should you know for understanding motor lesions? You should know that upper motor neuron lesions there are two types of lesions. An injury to upper motor neuron and injury to lower motor neuron. Upper motor neuron lesions are further subdivided into pyramidal lesion and extrapyramidal lesion below the level of the lesion. These symptoms will be seen below the level of the lesion. Pyramidal lesions will result in following symptoms. Inability to perform fine actions, Babinski sign positive, superficial abdominal and cremasteric reflex absent. Extrapyramidal lesion will result in severe paralysis, spasticity, exaggerated deep reflexes and clasped life reaction. You have to know this, okay? You don't have to read it, just know it, alright? And if the lesion is lower motor neuron, it will be seen at the level of the lesion because neuron is cut at that level. Okay. What will you see? You will see flaccid paralysis. You will see muscle atrophy. Take a screenshot of this. Remember, the upper motor neuron, if the spinal cord is cut, you will see symptoms on the same side below the level of the lesion. Lower motor neuron, you will see symptoms on the same side at the level of the lesion. Okay? Right. Let's go to sensory lesion. If the dorsal column tract is cut, fasciculus, gracilis and cuneatus, what would you see? You would see it would be an ipsilateral lesion with loss of tactile localization, inability to judge objects, weight, astereognosis and so on. I won't read all this, you should. Then lateral spinothalamic comes with an asterisk because here the fibers cross midline at the level of spinal cord. Therefore, cut on one side shows you symptoms on the opposite side. Contralateral lesion below the level of the contralateral symptoms below the level of the lesion. It is true for anterior spinothalamic tract as well. So if it's cut on one side, you would see symptoms on the opposite side, a few levels below the level of the lesion. Of course, at the level of lesion, you always see a zone of anesthesia. Right. Spinocerebellar tract, when they are injured, okay, then what you see is patient having inability to understand unconscious proprioception, and therefore patient has ataxia, which is not corrected by vision, and of course inability to perform smooth movements needing a lot of muscle coordination. So take a screenshot of this, remember it. So I'm not talking about lamination because I'm going to discuss it in the lecture itself. Enumeration of lesions that are going to be discussed today. Come. In my earlier lecture, I've already covered Brown-Séquard cord syndrome and complete cord transaction. Okay. Today I'm going to cover central cord syndrome, Syringomyelia, anterior cord syndrome, poliomyelitis, and amyotrophic lateral sclerosis. Fancy names, not difficult at all to understand and remember if you get the first part, the part that I've already covered. If you do that well, बाकी सब बहुत आसान है. ठीक है? चलो, let's see if we can understand it. Let's begin with anterior cord syndrome. Don't see the screen. Anterior cord syndrome means anterior part of spinal cord is damaged. When will this happen? This will happen in case of fracture of vertebra, dislocation, anterior spinal artery is damaged, herniation of intervertebral disc. In either case, all your anterior part of spinal cord is damaged. What happens to the patient? So all these tracts are going to be damaged. Some are descending, some are ascending. The anterior gray horn is lost. Okay. So again, now understand that you're going to divide your symptoms into which white matter is lost, which gray matter is lost. Okay. What is lost in white matter? What is lost in gray matter? Accordingly, you're going to work out motor loss. You're going to work out sensory loss. It's like solving a mathematical problem. So, motor, I can see my pyramidal tracts are quite intact. Both my lateral corticospinals are intact, right? So, no pyramidal lesion. But my extrapyramidals are very much affected. So, what I'll see is an extrapyramidal lesion. Sensory tracts. Sensory, I will see bilateral loss of lateral and anterior spinothalamic tracts. See this bundle? Lateral and anterior spinothalamic tracts are lost. So, extrapyramidal tracts are cut, lateral and anterior spinothalamic tracts are cut, and of course, my anterior gray horn is damaged. Okay. So, what are the motor symptoms patient will come with? Extrapyramidal lesion. Therefore, what will you see? You will see severe paralysis, spasticity, you will see deep tendon reflexes exaggerated, and clasp knife reaction. Okay. Question. Will I see an element lesion also? Will I see a lower motor neuron lesion? Of course, you will see lower motor neuron. At the level of the lesion, you will see an element lesion. Because at that level, the neuron is damaged, right? Which is supplying the spinal nerve and the muscle. So, what happens to the muscle? Flaccid paralysis and muscle atrophy. So, that is what is seen motor-wise. What about sensory? What are the symptoms of the patient? You are seeing the dorsal column is intact. So, touch pressure is intact. What I am losing is anterior and lateral spinothalamic. So, do you remember I told you, remember the two asterisks? Here is a tract which causes contralateral symptoms. So, at whatever level is the cut, you will see symptoms contralaterally. But in this case, it is bilateral injury. So, what you see is loss of pain temperature bilaterally below the level of the lesion. Okay? And loss of pain temperature bilaterally at the level of the lesion. But will I lose fine touch vibration? No, I will not, because dorsal column tracts are intact. So let's summarize. Motor symptoms, extrapyramidal, severe paralysis, spasticity, etc. Lower motor neuron lesion, flaccid paralysis, muscle atrophy, okay, at the level of the lesion. extrapyramidal, bilaterally below the level of the lesion. Sensory, there is loss of anterior spinothalamic, lateral spinothalamic on both sides. So below the level of the lesion on both sides there is loss of pain temperature. At the level of the lesion on both sides there is loss of pain temperature. Okay. Fine touch and vibration sense are intact. Now you need to work this out. You might feel I'm reading, but actually when I'm telling you, I'm understanding. So sometimes spinal cord lesions are best discussed, not read. Discuss it out. Okay. And you have to know the tracts. I have separately covered the tracts in the spinal cord series. Please study the tracts. You will understand everything much better. So with that, we covered the anterior cord syndrome. Let's go to central cord syndrome. Take a look to understand what's happening. Central portion of your spinal cord is damaged. How will this happen? Just try it out. You shouldn't damage your spinal cord, but hyperextension of the neck. If you extend the neck too much, okay, against the vertebral body, the spinal cord gets caught between the vertebral body and ligamentum flavum, getting injured inside the spinal cord. This is typically central cord syndrome. So here's your lesion. Take a look. Which white matter is lost? Which grey matter is lost? It's very easy. Okay. So I can see that a bit of my lateral corticospinal and my rubrospinal are damaged. I can see my grey matter is injured, damaged. So what will the patient come up with? Take a look. Corticospinal and the rubrospinal are damaged. Anterior horn is damaged. What is not seen is that from both the sides, the crossing fibers of lateral and anterior spinothalamic are also damaged. So bilaterally, the crossing fibers at the level of the lesion are damaged. I'll explain this to you better. So let's talk about the motor lesions now. I know I've lost lateral corticospinal tract, rubrospinal tract. Because my lateral corticospinal tract is damaged, I'll see a pyramidal lesion. Because my rubrospinal tract is damaged, I'll see an extrapyramidal lesion, right? So if the pyramidal tract is lost, inability to perform fine movements, Babinski positive, superficial abdominal and cremasteric reflex absent. What about extrapyramidal? Extrapyramidal will result in severe paralysis, spasticity. Okay, so just remember those blocks and put them there. You don't have to study it differently every time. You would go crazy remembering these lesions for every illness or every lesion. Just remember the block. Pyramidal lost, what is the symptom? Extrapyramidal lost, what is the symptom? And put them there. And then slightly modify it as per the lesion. Lower motor neuron lesion also. Yes, anterior horn cells are lost. So you will have at the level of the lesion flaccid paralysis and muscle atrophy. Pyramidal and extrapyramidal are below level of lesion. Lower motor neuron is at the level of lesion. I'll keep on repeating this till it enters your brain. Let's talk about a little bit more about this. Okay. Now here you are seeing that this is the lateral corticospinal tract. Ma'am, why are you coloring it like this with lines? No, I'm not doing anything. I'm just trying to show you what is the organization of fibers. Most medially there are cervical, then there is thoracic, then there is lumbar, and then there is sacral fibers. Okay, and can you see how the cervical lesion has spread out? And the central lesion has spread out? So what will the patient come to you with? Look at it and answer. Patient will come with saying that my upper limbs are not functioning well. They're paralyzed. Okay, and now because the cervical part is damaged at this level. Are the sacral or lumbar damaged? No. So will his lower limb be paralyzed? No. So you are able to understand that this is probably a central lesion, and that's why peripheral, the sacral and the lumbar are spared. Now when the patient says that initially it was only cervical, upper limb, madam, now my lower limbs are also feeling weak and seem to be getting paralyzed, then you know that it's a central lesion that is spreading. That's why you have to know concept of lamination of tracts in the spinal cord. Lower motor neuron lesion will also be seen. We've discussed that. Let's talk about sensory lesion. You remember I told you that the lateral and anterior spinothalamic tracts are crossing and these crossing fibers are damaged. I'll show you how that happened. So there is some pain. It has entered into the spinal cord. The second order neuron has crossed the midline in the center and ascended upwards on the contralateral side as lateral corticospinal tract. Now here's the lesion. You can see how the lesion may not be exactly cutting the tract, but it is definitely cutting the crossing fibers. Okay, this is shown only for one side, but same thing is happening to the fibers from the opposite side as well. All the decussating fibers in the center are damaged. Okay, so what will you see now? Loss of pain temperature bilaterally. Okay, below the level of the lesion. There will be sacral sparing. Why sacral sparing? I'll tell you why. Wait. And fine touch 2-point discrimination is all protected. Why? Because dorsal column is intact, no? So dorsal column is intact, so that sensation is preserved. Only pain temperature is lost. Sacral sparing, madam. Why? Take a look. These are the sacral, lumbothoracic, cervical. Can you see how the central cord lesion at this moment is only covering the cervical and thoracic spinal cord parts or fibers? So there is clear sacral sparing. Patient will say that I can't feel pain temperature in my upper limb and thoracic region, but I can feel it in the lumbar and sacral region, right? So this is the concept of sacral sparing, okay, in case of central any lesion of spinal cord. You have to know the arrangement of fibers. Syringomyelia, a slightly smaller version of central cord syndrome, where you can see a central cavitating lesion in the spinal cord. So I'm directly taking you to this. Here's the lesion. These are the pain and touch pressure fibers crossing the midline. Exactly where they are crossing, there is a lesion. So they cannot cross. So what will the patient come with? Bilateral loss of pain temperature at the level of lesion. Is the tract lost? No, the tract is not lost. You can see tract is intact. So pain temperature is being carried from above and below level of lesion. Only at the level of the lesion, it is hampered. You can see the tracts are intact. Touch sensation is unaffected. Why? Because fasciculus, gracilis and cuneatus is unaffected. You will say, ma'am, anterior spinothalamic is also carrying touch. You are so right. Yes, it's also carrying touch. But fasciculus, gracilis can compensate for that loss. So there is no loss of pain temperature, of touch sensation, but pain temperature are definitely lost at the level of lesion. Now, if this is called dissociated anesthesia, comes as an MCQ. Understand that as the syringomyelia will widen out, it will slowly begin to increase more and more extent of its spread. So lateral corticospinal, rubrospinal might be affected like the central cord syndrome. You might even see flaccid paralysis because the anterior horn cells are affected. You might see Horner syndrome. So as the syringomyelia will increase, more and more tracts will be affected, causing more and more symptoms. So what happens in poliomyelitis? You have all seen polio patients, isn't it? You've seen how they are usually disabled by the fact that there was a virus that affected their anterior horn cells, leading to death of the motor neurons in the anterior horn of spinal cord. So what will you see if anterior horn is damaged? It's a lower motor neuron. Therefore, you will see, I'm not going to show you. What will you see? You will see flaccid paralysis, okay, and muscle atrophy. So that is what you actually see, don't you? You see the flaccid paralysis, you see muscle atrophy in these patients, right? That is what happens in poliomyelitis. Finally, what is amyotrophic lateral sclerosis? What a fancy name. Actually, this is considered to be a familial disorder which affects only the motor system. You can see how it affects the anterior horn cells and the corticospinal tracts. Okay. Not much is known about this at this stage, except that because the corticospinal tracts are cut, it results in pyramidal lesion. What is that? inability to perform fine movements, Babinski sign, positive, superficial abdominal and cremasteric reflex, absent. But because it affects the anterior horn cells, it causes an element lesion. That means flaccid paralysis and muscle atrophy, right? So this is amyotrophic lateral sclerosis, which affects only the motor system. So students, today we've covered Central Cord Syndrome, Syringomyelia, Anterior Cord Syndrome, Poliomyelitis, Amyotrophic Lateral Sclerosis. In part 1 of this lecture series on lesions of spinal cord, I had covered Vaishaly Cord Syndrome and complete cord transection. VP Anatomy has taken all these lectures under the topic of spinal cord. Okay, all of these are now released on YouTube. I want all of you to sit and study your spinal cord well before you actually begin to study your brain. Remember, spinal cord is the foundation of CNS. If you know your spinal cord, you will understand the rest, otherwise you will not. Okay, so link for all these lectures is given in the description section. Please go and study all of them. Feel free to call me in case you have any doubts. Students, please like and subscribe to my channel, and please give me some comments so that I'll understand whether I'm really helping you out. One small request again, if you like this lecture, do share it with any one friend of yours. Okay, if you've liked it, let other person also enjoy and benefit from these lectures. Okay, so students, thank you. I enjoyed taking this lecture. I hope you enjoyed it too. See you across the screen in some other lecture on spinal cord. Next week, I'm coming up with MCQs on spinal cord for your PG entrance series. Okay, do attend those as well. Bye.